I'm Steve Crystal, lead of the Special Populations Corps and director of the Center for Health Services Research. And it's my great pleasure to introduce Dr. Brandon Marshall, whom I've come to know over the years from some very exciting work that is done through the VA cohort study, opioid work group, which has really produced a phenomenal set of papers from VA data. Dr. Marshall is Associate Professor of Epidemiology at Brown University School of Public Health and founding director of the People Place and Health Collective at Brown University. Brown is really doing a lot of stuff. Our longstanding colleague Vince Moore is there. Vince is still a force, right, Brandon?
Very much so, very much so.
His work focuses on substance use epidemiology, infectious diseases, and the evaluation of novel harm reduction strategies to improve health and well-being of people who use drugs. He's the PI of multiple NIH-funded projects, including the Rhode Island Prescription and Injection Drug Use Study, scientific director of PreventOverdose.org, works closely with Rhode Island Department of Health to address the overdose epidemic, serves as an expert advisor to Rhode Island Governor's Overdose Task Force, has served on an FDI advisory committee and associate editor of International Journal of Drug Policy, which we should look at as a target sometime.
Please do.
And it's my great pleasure to welcome him. So with that, it's over to you, Brandon.
Thank you so much, Steve, for that introduction. It's great to be here with all of you, albeit virtually. I'm going to share my screen. Give this a full. Okay. How does that look, Steve? Can you see that?
Looks great.
Great. Thanks, Georgette. So I'm going to talk about supervised consumption sites today. This is a topic that's near and dear to my heart. I was fortunate to serve on the scientific team that evaluated the first supervised consumption site, which opened in Vancouver in 2003. And now, almost 2 decades later, the first publicly recognized supervised consumption sites have recently opened in New York City. So hopefully this is a timely topic that's of interest to all of you today. What I'm going to do this afternoon is focus on what the scientific evidence says. I'll talk a little bit about how these facilities are typically evaluated and summarize their impacts, both on people who use these facilities and on the neighborhoods in which they are located. And then I'll finish with a discussion of what I think are some of the most important barriers to their implementation in the United States right now, and some thoughts on some future research directions as well. So before we get to the good stuff, just a couple disclosures. I have received funding from NIH, Arnold Ventures, and Cigna Foundation. I serve as an expert witness in the state of Rhode Island's lawsuits against opioid manufacturers and distributors. And as Steve noted, I'm also an advisor to the Rhode Island Overdose Task Force, and I'm an ad hoc member of an FDA advisory committee. So when we're thinking and talking about overdose, I like to keep the historical context in mind. And that is that drug overdose deaths have actually been increasing near exponentially for 4 decades. This figure is from a paper published last year in Addiction. I went ahead and took the liberty of adding the number of overdose deaths that was reported by the CDC in 2020, which was just under 92,000. So that was an unprecedented year, right? That was the first year of the COVID pandemic in the United States. And I think what made it unprecedented for the overdose crisis was that we saw super exponential growth in this problem. So I think you can look at this figure and say, we are not moving in the right direction. And we are unable to bend this curve seemingly. And I encourage all of us to think about novel policies and new interventions that have been successful in other parts of the world to try to bend this curve and save lives. So what has happened during the COVID pandemic is that racial, ethnic inequities in drug overdose have been greatly exacerbated. This is a paper that just came out a few days ago in the American Journal of Psychiatry, which showed that drug-related overdose mortality for non-Hispanic Black adults, which is shown in blue, is now on par with non-Hispanic whites in 2019, and it's actually now greater than that in 2020, which is the first time that's happened since 1999. Shifting racial trends in overdose reflect the profound ways that race shapes access to healthcare in this country, treatment, recovery, and also criminal justice. And I want to highlight that there's pervasive structural racism in healthcare, in drug treatment systems in the US, and also in our overdose response. And so I think as we're considering new interventions like supervised consumption sites, we must consider how these types of new programs might ameliorate or hopefully greatly reduce some of these racial, ethnic health inequities that really underlie overdose and drug-related problems in the United States. And this is a theme that I'll come back to throughout the talk. So this is a paper we published in International Journal of Drug Policy 2 years ago that looked at national drug overdose data, and we broke it down by state. States east of the Mississippi are shown in orange, and states west of the Mississippi are shown in blue, and we plotted age-specific mortality rates in each of those regions. What you can see is starting in 2013, rapidly increasing rates of drug overdose mortality, particularly in the eastern states. And that's where we have seen the introduction of fentanyl into the illicit drug supply. And that is one of the primary drivers of overdose mortality now in this country. But what you can also see are increasing rates in almost every age bracket. And so we have a massive national crisis here that we really urgently need to address. So that brings me to supervised consumption sites. So I want to talk a little bit about what are these before we get into what the research shows. These are community-based clinics where people who use drugs can consume pre-obtained controlled substances under the supervision of trained staff. Typically, these staff are medical professionals like nurses or trained peers. Clients, no, one thing I want to highlight and I want you to take away from today is that these facilities are a lot more than just the supervision of drug consumption. In the vast majority of facilities, clients can access a whole suite of wraparound services that includes basic medical care and other support programs, and critically referral to treatment and recovery resources. There are approximately 120 supervised consumption sites operating in 10 countries. The first one opened in Switzerland in the 1980s. The terminology in this space is rather confusing. These go by a lot of different names around the world: supervised injection facilities, safe injection sites. Yep.
Thank you.
You have a question? I'll keep going. In Rhode Island, we're calling them harm reduction centers or overdose prevention centers in New York City. For the purposes, there are small differences in this terminology. For the purposes of today, I'll refer to all of these as supervised consumption sites. So I want to take you inside North America's first supervised consumption site, which, as I mentioned, opened in the downtown East Side neighborhood of Vancouver in 2003. So when clients register to use the service, they do so anonymously and then enter into what's called the consumption room, which consists of 12 booths. You can see those in the background of the photo where the controlled substances are consumed. In the foreground of the photo is the nursing station where the nurses passively supervise the drug consumption and intervene in the case of an overdose. They provide Narcan or naloxone and also oxygen, but also provide a lot of other services as well: basic medical care, wound care, harm reduction and injecting education, and of course, sterile drug use equipment, which is shown in the lower portion of the photo. So as I mentioned, there are now 2 publicly recognized overdose prevention centers open in the United States, one in Harlem and one in Washington Heights in New York City. They are both located within existing syringe service programs, and they're structured in a similar way as Insight in many respects. You can see the consumption booths in the background of the photo and a station where the supplies are provided. There's also a whole suite of wraparound services, including direct engagement with and referral to low threshold treatment programs, including buprenorphine. Within the first 3 weeks of operation, they opened in the end of November of last year, staff averted at least 59 overdoses, and they've now had, I think, hundreds of clients, unique clients register, so really showing the demand and need, I think, for these services in these neighborhoods. So here in Rhode Island, we are the first state in the nation to authorize these facilities through state legislation. This bill was passed with broad bipartisan support last summer and signed into law by our governor in July. What's happening is that the Rhode Island Department of Health is now developing and finalizing a regulatory framework for what we're calling harm reduction centers. Those were actually just released last Friday. You can find them on the website there. And starting February 16th, any organization that wishes to apply for a license to operate a harm reduction center can do so. They will need to provide similar services like I've already talked about, as well as referrals to housing, employment, and legal assistance, as well as health services and referral to addiction treatment. Interestingly, in our case, the regulations mandate that all operators provide facilities for both injecting and inhalation of controlled substances. And that was done because there's evidence that here in Rhode Island, many people of color in particular prefer to smoke rather than inject drugs. So this was seen as a way, again, to increase access to and address health equity in our state. And the photo down at the bottom there is a photo of a mock harm reduction center that was opened in downtown Providence and really has been very successful. A lot of media has enjoyed being able to go in and see what such a facility will likely look like when they probably open sometime this year. So I want to now move to what the research shows, and I'm going to walk through 4 key questions that the Insight evaluation sought to answer and that have been evaluated in other contexts as well. The first is the one that I was interested in, which is whether these sites, supervised consumption sites, reduce community overdose rates. I told you already that overdoses are averted and addressed and managed in the facility. In fact, there has never been an overdose death within any supervised consumption site in any facility around the world. But what we wanted to see was whether these facilities actually have an impact on overdose mortality rates at a community level. So that's what we did. I published this study in The Lancet in 2011 with colleagues from the University of British Columbia. And I'm just going to walk you through really quickly the methods and then highlight the key results. So this is a population-based retrospective study. What I was able to do was obtain a sample of all deaths deemed by the provincial coroner's office to be caused by an illicit drug overdose between January 2001 and December 2005. Insight, as I mentioned, opens in September of 2003. And then we were able to map the location of each of these drug over deaths in terms of where they occurred pretty precisely using the 6-digit postal code from the coroner's reports. In Canada, a postal code represents an urban center is like a half of a city block, so a pretty high level of geographic resolution. We then looked at the area of interest, which was city blocks within 500 meters, about 550 yards of the supervised consumption site. We did that because of prior evidence that about 75–80% of people who use the SCS reside within this small vicinity in this small neighborhood. So we hypothesized that if we would see an effect, it would be largest in this immediate vicinity. And we considered as a quasi-control area all city blocks outside of this radius in the rest of the city of Vancouver. And then we just essentially calculated rate differences in overdose mortality in both of these regions, comparing the overdose mortality rates before and after the SCS opened. So this is a map showing all of the overdoses that occurred in the city of Vancouver over that 5-year period. You can see the downtown East Side neighborhood in the upper part of the slide. The supervised injection facility is located right in the middle of that neighborhood where the highest density of overdoses had been occurring for a long time. The downtown part of Vancouver is shown on the peninsula where you see another cluster. So these are the data now. I am showing you our intervention area, the neighborhood blocks within 500 meters of the SES radius and the quasi-control neighborhood. I show you both the number of overdoses in both of those areas before and after the facility opened, and the corresponding overdose mortality rates using census data as the denominator. What we found overall was a 35% reduction in community overdose mortality in the intervention neighborhood, compared to only a 9% reduction in the rest of the city of Vancouver over that same time period. This is a figure showing the results graphically. So the darker the color, the higher the overdose mortality rate. This is a block by block comparison of overdose mortality, really, shocking levels of overdose mortality in the downtown East Side before the facility opened, which is shown in the red star. We observed decreases in overdose mortality rates actually in every city block after the facility opened. We also looked at a different geographic unit of analysis, and the findings were generally robust when we looked at the analyses and the data based on the census tract, which is larger than a city block in Canada. So this figure shows you the rate difference again. If it's greater than 0, that means that the overdose mortality rate was higher before the facility opened compared to afterwards. And what we can see here, and then I've plotted the census tracts on the x-axis based on the distance between their centroid and the location of the supervised consumption site. And what we found was decreases, pretty significant decreases in these 2 census tracts that actually surround the facility, and really not a lot of change in the rest of the census tracts in the city of Vancouver overall. So I want to show you now data from an evaluation of an unsanctioned facility that had been existing in the United States since 2014. The location of this facility has not been ever publicly announced, just due to the concern and privacy and also potentially legal nature of these activities. This was published in the New England Journal a couple of years ago, just looking at the number of injections taking place in this unsanctioned site over 5 years, the number of opioid overdoses reported, and then the number of overdose deaths in the site, which is, as I mentioned, like in every site, 0. You can see here overdoses, especially per 1,000 injections, have increased pretty dramatically as in this context, fentanyl has been introduced into the illicit drug supply. So I want to move on now to the second question, which is whether the supervised consumption sites can help people enter treatment. As I mentioned, this is a primary goal of many of these facilities around the world, is to connect people with healthcare, and that includes substance use disorder treatment services. So one of the first studies that looked at this was published by my PhD supervisor in the New England Journal of Medicine in 2006. What was done in this study was a linkage study. Basically, they enrolled a random sample of 1,000 people who used the supervised injection facility and linked their data in terms of utilization of the SCS to the city's database of detoxification programs. Evan looked at detox because at the time, way back in 2003 to 2006, that was one of the main primary modalities of addiction treatment at that time. So these are the results from a bivariable and multivariable survival analysis. What you can see here are variables that predicted uptake of entry into an inpatient detoxification over that 3-year study period. And what I want to highlight for you is that people who used the SES pretty regularly, that is at least weekly, were about 72% more likely to enter into an inpatient detoxification program than people who weren't. And that was after accounting for other predictors of entry into detox programs shown in the variables above. What I want to highlight as well, independently in fact, was that speaking with an addictions counselor on site increased by about twofold the likely into an addiction treatment program. This is really critical. This service typically happens post-consumption in what's called a post-consumption room or chill-out room, where you have peer counselors or addiction counselors able to build rapport with people, talk to them about treatment options, and connect them to services. And what this study shows is evidence that that's really where you see that engagement happen and where those connections can be effective. So that's just looking at detox. A follow-up study conducted by my colleague Cora DeBeck looked at other forms of entry into treatment program. This is self-reported engagement in any kind of treatment, things like peer support programs, methadone programs, and so forth, looking over about a 2-year follow-up period. In this cohort, about 600 people were not engaged in any treatment at baseline, and over 2 years of follow-up, about 40% of people reported entering into some form of treatment. And the results in terms of predictors of entry into treatment was very consistent from the prior study: regular attendance and contact with addictions counselors at the supervised consumption site were independent predictors of uptake of some form of treatment in this study. All right, so when I give talks on supervised consumption sites, a lot of questions I get asked is, okay, well, they may benefit people who use them, but what is the impact on the neighborhoods in which they're located? So this is a key question, I think, for cities and neighborhoods that are considering implementing these interventions. And so we and others have sought to answer that question. So I'll show you some of the data now on measures of public disorder and crime. So this is one study that was one of the first that was published in terms of the evaluation of insight way back in 2004. What was done here, I really love this study. I'd love to replicate this if and when sites open in Rhode Island, is the following. So we had research assistants, students, basically go out and canvass that same neighborhood that I mentioned, the downtown east side neighborhood of Vancouver, 6 weeks before Insight opened and 12 weeks after. So the opening of the facility is shown by the dashed dotted line, and they conducted a social systematic observation where they essentially counted the number of publicly discarded syringes that were observed, the number of people injecting in public, and the amount of injection-related litter over that time period. And you can see the comparison in terms of the number of people daily using the facility at the top left of the screen. So what you can see is significant decreases in all 3 measures of drug-related public disorder. This finding was actually stable and robust when they accounted for other predictors such as weather and police activity in these in this neighborhood. Several studies have looked at the impact of supervised consumption sites on crime. This was a study published actually not too long ago, about 4 years ago, by American researchers. So this was not done by the Canadian evaluators. They were able to obtain Vancouver police report data and conducted a time series analysis to look at trends in arrest rates and other measures of crime in Vancouver over the period in which the supervised consumption site was operating. And I just highlight for you the takeaway message, which is that overall, they observed no impact of the supervised injection facility on crime. And in fact, when they disaggregated the data by district, by VPD districts, they only found a decrease in crimes in the district where the supervised injection facility was located. Now, this is a time series analysis that could be due to other reasons, but certainly no evidence that the opening of these facilities is increasing crime. If anything, they are improving the neighborhood conditions in which they are located.
Brandon, you have a couple questions in the chat.
Oh yeah, let me take those.
Take a quick.
Thanks, Melissa, for answering these questions. Happy to clarify. So she asks, does the SCS provide the substances to be consumed? No, in the vast majority of facilities, people bring and use pre-obtained controlled substances. And that is what's happening in New York City and what will happen here in Rhode Island as well. And her second question is, how long does the person stay after ingesting substances? Do they have to stay to speak with an addiction counselor or remain in the building for a period of time, or are they free to leave post-consumption? Typically, people are free to leave. Many stay for, 15 minutes, up to an hour, 2 hours. They may interact with counselors or want to talk to them about other services like housing programs, for example. But no, typically there's no mandated amount of time that they have to be observed. There may be facilities in other countries that have different policies, but most facilities in Canada do not mandate a minimum observation period. Good questions. Oh, one more. Oh, great. Oh, and Maria asked, do sites test the substances? Great question, Maria. So yes, most supervised consumption sites nowadays will offer drug checking programs, either fentanyl test strips, which are kind of like rapid COVID tests that detect fentanyl and related analogs in a small amount of drug sample dissolved in water. Some will also have what I call fancier equipment like mass specs that test for other substances as well. And typically people might use those services prior to consumption, or they might just use the drug checking program and not necessarily have to consume on site. So yes, that is a service that is typically provided at most Canadian supervised consumption sites. I have to find out what they're doing in New York City. Actually, I'm going to write that down because I'm not sure. Great question. So just to close out the discussion on crime, this is another time series analysis from the unsanctioned safe consumption site in the United States. This was published in Drug and Alcohol Dependence, I think in 2020, I believe. So what you're seeing here are counts, standardized counts of drug and narcotic specific police incidents reports in the neighborhood in which the unsanctioned SCS is located. That's shown in green, and the opening of the facility is shown by the vertical dashed line. And these authors looked at 2 control regions. The one shown in red is what they called a location-based control. That's basically the next neighborhood beside the neighborhood in which the SCS is located. And then control 2, shown in blue, is a characteristic-based control. That's a neighborhood in the same city that has the most similar characteristics, higher rates of poverty and homelessness, for example. And what you can see is that overall crime, particularly in the neighborhood in which the SCS is located, really was decreasing before it opened, and that kind of leveled off to a pretty stable level. When they did a formal time series analysis, there was no discernible comparative impact between the intervention neighborhood and either of the controls. When they looked at a broader set of endpoints, this is any police incidents in the intervention neighborhood and the control neighborhood, so burglaries, thefts, robbery, etc. There was actually some evidence in the time series that there was increase in crime before the facility opened in the neighborhood in which it's located, and then that turned around. You can see that by the inflection point there, and less so in the blue control region. Overall, though, again, really no evidence here that these positively influence crime. If anything, they again contribute to improved neighborhood conditions in the areas in which they're located. Okay, so the final question I want to propose to you before some closing thoughts is, do people actually use these? And I think we've seen in New York City that the answer is yes. In fact, there's a very high demand for these services. People know about the penetration of fentanyl in the drug supply. They're concerned about overdose risk. That's typically what we see here when we do studies of people who use drugs in Rhode Island. But this is one very small study we did several years ago from a pilot, just a very small sample of young adults who use prescription opioids non-medically. This was a sample of 200 people, but a fairly small number of people were actively injecting. And unfortunately, only they were asked a question about interest in and willingness to use what we at that time termed a supervised injection facility. So pretty small sample there. The vast majority of people said they would be willing to use an SCS. And again, this was done 5 years ago, and there was very little discussion at a state level or nationally about what these services are. And that we were able to look at some predictors of willingness, and things like homelessness, lifetime overdose experience, and daily drug use were predictors of increased willingness to use an SCS, which is what we've seen in other studies. These services are typically used by people who have moderate to severe substance use disorder and who may be experiencing homelessness and have a long history of overdose. We also asked about how far people would be willing to travel. And again, not too far. Most people said they'd be willing to travel up to 20 minutes, highlighting that to be most effective, they need to be located in areas where people who are at risk for overdose reside. So in terms of implementation, it's important to think about where they may be most effective. That being said, I do want to highlight that there are other different modalities available besides a large brick and mortar standalone service like you see in Vancouver, even in New York City. This is an example on the left of a mobile supervised consumption site. This is actually in my hometown of Kelowna, British Columbia, which is a fairly small town of 135,000 people. So this is a converted RV which travels around. The idea is to increase accessibility and access to these services when you have a more disseminated population at risk. You can also integrate these services into existing facilities. The figure on the right is an example of just a very small supervised consumption facility, only 2 chairs there, integrated into a residential day program for people living with HIV in Vancouver. So just to sort of wrap up now, some thoughts on some future research directions. This was a systematic review that I published with some colleagues at BU that came out last year. We did an updated systematic review and, has shown pretty consistent support for positive effects on overdose morbidity and mortality, reduced engagement and risk behavior, and improved access to addiction treatment programs. Those are shown by the double crosses. But there are some limitations to the previous literature. You can see that the vast majority of the evidence comes from Canada and a few other countries, including in Europe and Australia. So we certainly need more research from low and middle income settings, one, and also, of course, here in the United States. Secondly, this research is very challenging. It's, not feasible to randomize this intervention. Many of these studies have used what I would call like quasi-control groups or comparison groups of people who use the facility less frequently. But I think thinking more thoughtfully about a true comparison group would improve the rigor of the body of literature broadly. Third, we don't know very lot about comparative effectiveness. These facilities, as I've shown you, look very differently across the world, and we don't actually know, what components of supervised consumption sites are most likely to be most effective for specific people in specific settings. So if this intervention rolls out in several settings across the United States, we'll have a lot of really tremendous research opportunity to understand how to make them most effective. And finally, I think we do need more research to understand how they can play a role more broadly in addressing racial ethnic health inequities. My view is that they're going to be most effective when they're paired with broader policy change focused on things like decriminalization efforts and reforms to the criminal justice system. So just to highlight some barriers I see to implementation. I talked already about the racialized approach we've taken to drug-related problems in this country. And I think at a public level, general public level, very poor understanding of substance use disorder. And these two things combined make it very challenging in the United States to consider novel, compassionate, evidence-based interventions. And so we have a lot of work to do in educating policymakers and the public about why these types of interventions work. I've also seen, when I present on this topic, a lot of myths, right? That they increase crime, that they increase public disorder. And I hope I've shown you that that's not the case. I think number 3 is one area where epidemiologic research can play a role. And then, of course, legal barriers in the US too, particularly at a federal level. There may be people on the call who are more familiar with the Safe House case, which is still pending in federal courts. But I do want to highlight an article that just came out yesterday, which is that the Justice Department may be considering at least allowing these sites to open in jurisdictions that have already authorized them, like New York City and Rhode Island. So that's certainly good news for operators who have been rightfully concerned about a federal interference on their ability to operate and provide these types of services. So we'll see where this goes. I'm not a lawyer and not really able to comment on the what we'll see, but I was happy to see this position coming out from the federal government just yesterday. So one more closing thought for you before we have lots of time for questions, which is where this intervention fits in a broader US overdose response. I'm kind of an equations person, and this is a rather simplistic way of thinking about the problem, but I find it helpful. If you think about the number of overdose deaths each year in this country, kind of distills down to like 3, terms in this equation that I just came up with, which is first the number of people at risk for overdose, right? The number of people who may experience an overdose. The second thing is that beta, which is their risk for overdose per year. And the third term is the risk of death per overdose, because not every overdose is fatal. What we've seen, of course, is that fentanyl has increased all 3 of these terms. It's greatly increased the number of people at risk, it's increased the risk of overdose per person using, and it's increased, I would argue, the risk of death per overdose event. And so that, I think, is one mathematical way to understand why we're seeing such incredibly high rates of overdose at sort of a basic quantitative level. And so what you want to do is think about how interventions could impact and influence one or more of these terms. And I would argue that supervised consumption sites attempt to do all 3, right? They try to reduce the number of people at risk by providing a pathway into treatment and recovery services. They try to prevent an overdose from happening in the first place by providing harm reduction education and supplies. And then, of course, by immediately supervising the overdose, they decrease greatly the risk of death, conditional, and overdose happens. But that being said, they're not a panacea. We need lots of interventions that hit on all of these terms: prevention, other harm reduction tools, naloxone, right? They all play a role in trying to drive down that number that we care so deeply about, and with the goal of saving lives. So with that, I want to just finish by acknowledging participants for their willingness to contribute to this research, the wonderful team that we have here at Brown at the People, Place, and Health Collective, including staff and faculty who have helped me with this material. Original funding for the Insight evaluation was provided by Health Canada and the Canadian Institutes of Health Research. We received some center grant funding from NIGMS. And I'd also like to thank Magda Serda, Thomas Kerr, and many others for their collaboration and mentorship. So with that, I'll stop and just highlight that you can certainly email me or follow us on Twitter. We also have a Medium page as well, where we post periodically about harm reduction and other public health issues in the US. And that's it. So
Wonderful.
Stop my share.
So to start the discussion, first I just want to make sure that for those who don't happen to be following the chat, that Maria asked about receiving the recording or slides, and Georgette has advised everybody that there will be a recorded version of the talk on the Special Populations website in the next couple of weeks. So that's the place to check. And if somebody wants to dive in, I'll just give a moment to see if anybody wants to jump in verbally, and then we'll monitor the chat. I have a couple of questions queued up also.
Great.
I'd like to ask a question.
Yes, I was guessing that.
So the video on. Thanks,
Yes.
Dr. Marshall, for the talk. It was really interesting, and it's obviously really crucial sort of next public health intervention. I was wondering, obviously overdose is kind of the most like prominent and concerning aspect of deaths related to injection drug use, but I was wondering if anybody has looked at or started to look at sort of like, I guess like secondary deaths like related to severe bacterial infections or other things, and sort of what like the effects of these sites could have on those rates.
Yeah, great question, Michael. I focused on overdose, but my infectious disease colleagues say to me, keep highlighting infectious disease sequelae as well. So I have to do that. So yes, right. The studies have shown that these sites, particularly for injecting populations, reduce the risk of subcutaneous injection-related infections, things like endocarditis. There's been some initial cost effectiveness modeling in Canada that has shown that actually that's where a lot of the savings accrue. These are incredibly expensive conditions to treat and can be prevented with the provision of sterile equipment and harm reduction injecting education. So, you know, I would hope that any evaluation that is being considered in the US, you know, thinks very much about those. Hepatitis C and HIV was challenging for us to assess in Vancouver for a couple reasons. By the time this site was implemented in 2003, there had already been an explosive outbreak of HIV and hepatitis C. Hepatitis C prevalence was somewhere in the range of 70%, I believe. And so there wasn't enough people at risk in our cohort studies to actually look at incident risk of incident infections. And then of course, with new HIV treatments, HIV incidence during the post period was simply too low. So that's something we haven't definitively shown, but I think you could, hypothesize the same mechanism, right? That these facilities reduce syringe sharing and improve healthy drug use practices, healthier drug use practices.
So
Yeah.
Brandon, that actually sort of prompts a related question, which wouldn't this be a very appropriate place to start integrating primary care if funding was available for that?
Yeah, definitely. So these sites are structured differently. There's one organization here in Providence that has considered applying for a license that's more of a primary care setting for actually LGBT populations, but they're located in a neighborhood where there is a lot of public drug use and overdose. And so, when I talk to the operators, that's at the forefront of their mind, Steve, is like how you could integrate this into a more primary care setting and have it be part of a continuum of care. So there's not a lot of examples of that internationally as far as I'm aware, but I think it could be a very effective model.
Do you have any sense of people's interest in being screened, for example, for Hep C?
Yep. So that does happen in some places. And you could certainly imagine either having a strong referral pathway to hepatitis C treatment programs or potentially, provision of treatment on site, right? Depending on the degree of other services as well. Yeah. So less research about that though, certainly.
So the other question about treatment on site, and it gets into the weeds a little bit, but the exact process by which people get invited to enter buprenorphine treatment and have a warm handoff. So how exactly do you do that? For example, is there a way for any of that to be on site? Is there a way that representatives of the program can actually meet the individuals and say, this is our program, I can give you an appointment right now, or even I can give you some strips right now as a bridging mechanism. So are those kinds of things happening?
That is fascinating, Steve. I think about this all the time. So I need to learn more about how exactly it's working in New York City. I believe that there are buprenorphine providers on site. I just don't know exactly the clinical structure and protocol. So I'm going to find out. But in other settings, and what we've talked about a lot here in Rhode Island, is potentially what you're describing, writing, having a provider or a PA even write the scripts, and then potentially encouraging home induction is one option for people, because you're right, you can't immediately induce on buprenorphine post-consumption, as you know, right? So it's a little tricky to do post-consumption on site. So I think home induction is one option, or having those conversations prior to consumption. That's something I'd love to see some data on, right? As sites in New York City gain more experience with this, is that something that's feasible? There's a lot of different models to explore, certainly. Yeah.
I want to give other people a chance to jump in with their questions, and I hope that somebody does, because I'm sure you all don't want me to put you on the spot. Jim, I was seeing that you might have some interest.
Yeah, I was curious, like in terms of taking this research and like communicating with communities of interest, how has it been, if you have like engaging the police and law enforcement? I would think like an enterprising prosecutor could just show up at these places and bust like everyone there. So like, how is there any research that's been done on like how to engage with them? Do you just kind of hope you have a good ear down at City Hall, or do you have any thoughts on that?
Yeah, I do. So it's such a good point. I almost like to think of it as part of the intervention. Like, you have to get some degree of law enforcement buy-in for the intervention to be successful, because otherwise, as you say, law enforcement could harass people directly outside the site, arrest people. So that would make it highly, ineffective. So in New York City, there was essentially an agreement made between the mayor and the operators and the borough district attorneys, I believe, that they wouldn't prosecute anyone operating, and they wouldn't bother anyone who was using the facility. Here in Rhode Island, we're fortunate, I think, because we have a state law, right? And so the initial conversations with law enforcement, as far as I'm aware, have been relatively positive, because we can point to that state law and say, this is legal here in our state, and these are the goals. And I think those have been generally positive, but it's an engagement process, and it's slow. I think in terms of what can be most effective is having law enforcement talk to other law enforcement. So that's one strategy that has been deployed. Law enforcement officers who have a lot of experience with this in Canada have done, lots of engagement and speaking with other settings that are just considering implementing them. So that's one way to try to get over the hump. But to answer your point, it is a concern, and it does need to be addressed before I think you just go ahead and open up supervised consumption sites. Yeah.
Brendan, thinking about the sort of the broad population health level, and thinking about that exponential curve that you drew, which has always been very compelling.
Yeah.
There was an earlier study in the Lancet that sort of found that there's some rotation among different drugs, but when you look at drug use and drug problems overall, it's very much that exponential pattern over that very long time period. So given the scale of the issue, and just thinking about political possibilities, across this large country, and just thinking about if indeed the primary service area for sites is going to be relatively geographically small, so one would need a lot of them to really make a big dent. How do you see? I don't want to put you on the spot to think about the politics, because one should always envision what should be done and then move forward. But just thinking about the larger problem, what are the possibilities that this could really bend that curve, and if not, what are the other some thoughts about the other possibilities. I mean, we've been trying all these different things, and we've now been expanding buprenorphine, and we've been and nothing has really made a dent in the problem yet. So what do you think about this sort of this larger picture?
Yeah, and where do supervised consumption sites play that role,
Exactly.
Steve? It's such a good question, and that's why I don't, when I give these talks, I don't want to give the impression that this is a silver bullet, because as you point out, the scope of the problem is so large. We estimate here in Rhode Island that at least 50,000 people are at risk for overdose, and so that's a tremendously large group of people who need different types of services and interventions, right? It's a very broad spectrum, especially now with fentanyl in the stimulant supply. But nonetheless, I think that these do play an important role. They are reaching people who are among those at highest risk for overdose death. And so it's, sort of a focused but high impact intervention, if you will. They're also shown typically to be cost saving because they do a lot more than just prevent overdose deaths, as we've talked about. They prevent ED visits, hospitalizations, because overdoses are effectively managed on site. So they have other benefits, right? They relieve pressure from hospitals, which is incredibly important right now during the COVID-19 pandemic. In terms of scale, as I highlighted, there is a mobile site in my hometown. It's a fairly small conservative town in Canada. We here in Rhode Island had people come to speak to us who are from Grand Prairie, Alberta, which is like north of Edmonton, if you can believe. So it is up there. It's a town of about 60,000 people in the northern prairies, and they've implemented this service, seeing the need for it in their communities. So I do think I don't want to give the impression that it's just for large urban centers like Philadelphia, New York City, Boston. I do think there's scalability in terms of many sort of large and medium and even smaller sized towns, but it needs to be like part of a broader package of interventions too.
What would you say about how much of the benefit could be, because you sort of got a double benefit from having a site where people can come and engage in services and get clean needles and have access to naloxone and other things. So if you think about the safe injection aspect of a harm reduction site compared to maybe the less optimal, but perhaps more now politically acceptable option of the sites like we have in Atlantic City, here in New Jersey, which has escaped a near-death experience, but where people can get the services other than supervised injection. How much of the benefit could one get by doing harm reduction at scale, even if you're not able to get, and is it a pathway perhaps to what could ultimately be safe injection? But what's the role of sort of the other model of harm reduction?
So I think two things. It's such a good point, right? First, I would say yes, by all means, we should dramatically scale more fundamental harm reduction services and make sure they're supported, greatly increase their funding, and certainly make sure that they don't close. So I'm happy to hear the one in Atlantic City is going to remain open. Like, if we can do anything, we should do that, because the benefits of those types of services are very clear. But, and this is sort of my hypothesis more than anything, just to my observations doing this work, is that the added benefit of the supervised consumption piece, beyond just the immediate overdose reversal, is that for people particularly with, say, like severe opioid use disorder, many of our interventions are interacting with folks when they're feeling their worst, like when they've been reversed on naloxone and are in precipitated withdrawal or sitting in an emergency department. Like, I'm running some of those studies here, and it is just, when you think about it, like, is that the good time to talk to someone when they're feeling horrible and in an emergency department and maybe have a lot of poor experience with the healthcare system? And so a supervised consumption site is the one place where people can use, and maybe that is part of the quote unquote magic, right? That's when it's a more sort of amenable time to have those conversations and those connections happen.
And
So I
those
can't
sites
point
that
to
you're
any data,
looking
but
at-
that's just my thought. You know what I mean?
Yeah.
I can't point to any data on that, but and if you have an idea for how to study that, I'd love to hear it, but that's my thought.
Oh, there's a million ideas for studies, that's for sure. But in those sites, if people are in withdrawal in, let's say, a overdose or reversal situation, and I don't know the clinical answer to this. If buprenorphine on the spot is offered, does that put people in a place where they're perhaps more not feeling so bad and more receptive to taking the next step?
We'd hope so, right? I can't think of any study off the top of my head, but that's a good question.
Yeah, that's an interesting question. Final question, because we do have to wrap up.
Sure.
What are your thoughts on this rather dramatic increase in risk in the African American community that we've seen? I mean, what is all of that about? Is it about people who have been very long-standing street drug users who are now really affected by fentanyl and trends like that? Because those have been around for a while, and we hadn't seen them quite in the past hitting those inner city communities that much. Or, you know, what do you see this as really being about? Is it COVID related? Is it any thoughts?
It is complex, Steve. I don't think there's one singular driver of some of those changes that we saw and we have seen in some of those papers, but it alarms me, you know, because of the decreased access to evidence-based healthcare treatment and recovery programs, which I mentioned. We've looked here at our methadone rates in Rhode Island, and they're about half that for Black Rhode Islanders as they are for whites. So we have a lot of work to do to improve access to people of color in this country. So I think that's certainly part of the problem, right? And we've done other work that's shown that a lot of treatment and resources are also spatially segregated. And so it's, you know, there's access issues beyond, say, you know, the insurance or other financial barriers. There's geographic barriers as well. So I think as this problem continues to expand, we really have to look broadly and address the whole suite of, you know, environmental barriers that people of color face.
Really awesome. And we do have to wrap up. Georgette is reminding me, but
Yes,
so
Brandon, thank you
we
so
wanna
much.
thank you for a
Fantastic.
talk.
Thank you, everyone. I appreciate your time. Thanks again, Steve, for inviting me too. This was
Yeah,
great.
thank you. It was just as great as we expected.
Take care,
If not
everybody.
greater. Bye.
Bye-bye.
Thanks, bye.